Talk to you about some very early research in bipolar disorder, looking at very much the theoretical side of things, early maladaptive schemas in bipolar disorder. So first, a quick look at a reminder of what is bipolar disorder. It's characterized by mania and depression, mania being episodes of acceleration, grandiosity, heightened self-esteem, racing thoughts. Depression, we're all pretty much aware of, depressed mood, loss of interest, etc. But it really is a continuum. We have the extremes that create bipolar 1 with full mania, full depression. We have hypomania, which is like mania, but not as long in duration or severity. With depression makes bipolar 2. Subclinical depression with hypomania gives you cyclothymia. And subclinical mood fluctuations that we all experience. Bipolar disorder is present in about 2.2% of the population, fairly common. It's largely genetic, about 80% is due to genetics, but there is an environmental component. It's a chronic condition, recurrent relapses. There are a lot of symptoms between episodes, and there are many layers of complexity. There's much more to it than the pure so-called pure mania, pure depression. It's a very complex disorder. Comorbidity is the rule rather than the exception, and there are lots of complex findings. The treatments, first line of treatment is medication with mood stabilizers, antidepressants. Psychotherapy has also produced benefits for people with bipolar disorder, particularly psychoeducation, CBT, but they tend to focus on symptom management. The effects are moderate. They do provide benefits, but the effects haven't been spectacular quite yet, so there is room for improvement still. Why would we apply schema theory to bipolar disorder? This is used mostly with the personality disorders. Why bipolar disorder? There are 4 areas that say that we might want to apply this. First, early environment. About half of people with bipolar disorder report having experienced childhood trauma, and there are many different types of negative early experiences that these people report. Abuse, death, failure, all these different things predict the development of a bipolar disorder. Life events have been found to trigger symptoms. 90% of people with bipolar disorder report having experienced major stressors prior to onset, and almost as many before their most recent episode. There appears to be a congruency, whereas negative stressors will lead to depression, and goal-striving, activating stressors lead to mania. And this seems to act through cognitive appraisals. There's a way that we're interpreting these negative life events that lead to the development of symptoms. So what are the cognitive appraisals? We see a lot of high confidence among people with bipolar disorder, suggestive of entitlement or grandiosity. A lot of impulsivity, suggestive of insufficient self-control schemas. There's a lot of goal-striving cognitions that might be related to unrelenting standards. And this is a stable cognitive style. It's not just associated with the episodes. It's also present when they're euthemic. Lastly, there's a lot of similarity between borderline personality disorder and bipolar disorder. You could say it's the Axis 1 sister, if you will. They share similar environments, early environments, similar symptom profiles, similar responses to medication. There's a lot of discussion in the literature about whether these actually are 2 different disorders. It does hold up under research. They do appear to be 2 different disorders, but the discussions alone show you how much they have in common. And as you all know, schema therapy works for borderline personality disorder. So if we're going to share treatment, we're going to share environment, we're going to share symptoms, we're going to share medications, let's share psychotherapy treatment successes. What is the evidence to date of schemas in bipolar disorder? There's not tons. Nilsson and colleagues presented a small data set comparing borderlines to bipolars. They found that borderlines were higher on most schemas, but bipolars had higher scores on insufficient self-control and trends for 9 more. In a small sample, this was preliminary evidence, that there might be some schemas going on in bipolar. Then our first study, we looked at schemas in a non-clinical sample, people with, we identified people who were at risk of developing borderline bipolar, and we found 3 main schemas. In addition to a general activation, these people had higher schemas overall. They also had entitlement grandiosity, insufficient self-control, and a negative score on emotional inhibition. All of these fit with the characteristics of bipolar disorder, which gave us the go-ahead to check out the schemas among a diagnosed sample. So that's what we're looking at here. We're looking at the EMSs in patients diagnosed with bipolar disorder. Our hypotheses first was that there would be a general activation. Bipolars would have higher scores than non-clinicals. We were also looking for some specific effects based on the non-clinical sample, higher scores on entitlement and grandiosity, higher scores on insufficient self-control, and low scores on emotional inhibition. I had 74 participants with bipolar disorder, 99 mixed clinical controls. This was a mixture of mostly depressive and anxiety, but there were all kinds of things mixed in together, Axis 1, data collected in Quebec, Canada. Measures the schema questionnaire 3, Beck Depression Inventory, and Altman's Self-Rating Mania Scale. Quick look at the correlations. There are a lot of schemas there. It's a long list, but what you see quickly is that every schema, without exception, is correlated with depression. No schema, without exception, is correlated with mania. There wasn't a whole lot of manic symptoms in the sample. There were some, not enough to create any kind of correlations. There was quite a bit of depressive symptoms. Plenty for the correlations. When we compared the groups, what we saw was that for these 11 schemas, the bipolar group was at an intermediate position between the non-clinicals and the mixed clinical controls. They had significantly higher scores than the non-clinicals, lower scores than the mixed group. But for 3, the bipolars were equal to the non-clinical. The absolute lowest score was for emotional inhibition. Remember, we were looking for a negative effect. We wouldn't expect people with the emotional intensity of bipolar disorder to have high scores on emotional inhibition, and they don't. It was the lowest number to report clinically significant levels of the schema. There were 2 schemas where the bipolar group had equivalent scores to the mixed group. The highest percentage finding clinically significant scores was for insufficient self-control. We were also looking for that as a high score. In one case, the very highest group was the bipolar group, and this was for approval-seeking, recognition-seeking. They had higher scores than anyone else. And for one, it was non-significant across the 3 groups. I'm going to talk about this one for a second. We were looking for a higher score in entitlement grandiosity, since entitlement is actually a diagnostic criteria of mania. For one thing, we didn't have a lot of manic symptoms, so that might have had an effect. We also know from the non-clinical data set that my sample had, the non-clinical sample had extremely high scores on entitlement grandiosity. In fact, out of the 18 schemas, it was the one and only that was not different between a non-clinical group and a clinical group. My non-clinical sample was young university students in Quebec. It would seem that there are certain values or certain ways of thinking that are valued, that are picked up by entitlement that might be valued among that population. I could interpret it according to the recent events in Quebec, but I will not. And then we broke down the mixed clinical group. Most of them had unipolar depression or anxiety, so looking for some kind of specificity here. These are moderately powered. This isn't an extremely high-powered analysis, but it was worth trying to find some kind of specificity. What we find is that if we, in the first column, if we don't control for symptoms, there are a couple different differences that come out, bipolar being a little bit lower. But what's more interesting is when we start controlling for the depressive symptoms, because remember, there were quite a few depressive symptoms in the sample, and then what comes out is approval-seeking, recognition-seeking. Bipolars are higher than the unipolar. Entitlement grandiosity, there it is, we do have it. Bipolars are higher than the unipolar when we control for the depressive symptoms. So if we bring that all together, we were looking for a general activation effect. We did find that. That alone is a very important finding, because if in general bipolars have higher schema scores, we've got something to work with in therapy. We were also looking for some specific effects, and we did find what seems to be a core schema profile for people with bipolar disorder. Entitlement, grandiosity, insufficient self-control, both high. Emotional inhibition, rather low. This is consistent with the 2 previous studies, so I think we can be confident about these these 3 schemas. We also found a few other effects. There was a high score for approval-seeking, recognition-seeking, and enmeshment, undeveloped self. They were both trends in the Nielsen article, so there might be something there. They didn't really come out in the non-clinical article. Approval-seeking, that might be related to the goal-striving activities we see a lot among people with bipolar disorder. They'll always be working towards, striving towards achieving more. It may be that they're doing this in order to gain approval from the people around them. Enmeshment. Bipolar disorder has the curiosity of requiring you to be nervous about feeling good. So once you're diagnosed, you're suddenly putting your life into context. Every time I felt good, every time I achieved really good things, was this me or was this the disorder? So it's very reasonable to think that there might be some kind of identity disturbance that happens possibly after diagnosis, once they're starting to put a clinical name on everything good that happened in their lives. All of these schemas that came out do correspond with the characteristics of bipolar disorder. There are, of course, limits like any study, more females than males. I didn't assess axis 2 traits. That would have been nice to see. I also didn't assess the burden of illness. I would think that those who have a heavier burden of illness might have higher schema scores. That would be something to look at. My non-clinical comparisons, like I said, young students, specifically in Quebec. But I think we can from this conclude that the early maladaptive schema component of schema theory can be applied to bipolar disorder. Future research. I could talk for a long time about this. This is very early research. We haven't gone much further than this yet, but as far as theory goes, it would be nice to look at schemas as a mediator between life events and symptoms. Is this why stressful life events are leading to manic and depressive symptoms? We could look at the modes, at the coping mechanisms. We could look at the different types of bipolar disorder, burden of illness, schema therapy. Of course, this is what we ultimately want. It would be nice to adapt it to bipolar disorder, do some studies here, look at quality of life. It would be important to adapt it. This is going to have to be discussed by bipolar researchers and schema therapists. We'd have to adapt the treatment rationale to the fact that bipolar disorder is a chronic illness with a biological basis. We might want to adapt the protocol to account for the fact that there will be relapses. We don't have a cure to bipolar disorder. Here are some ideas to start the conversations on adapting it. The treatment rationale that I propose is that toxic early experiences in this clientele leads to high schemas for many patients, not all. EMSs may complicate the course of illness. If EMSs are mediating the relationship between life events and symptoms, we can treat the schemas, reduce the vulnerability to relapse, improve the quality of life, improve the course of illness. Thank you.
I treat a number of bipolar people now for several different ones over several years using schema therapy.
Excellent. You have data?
Oh, it's right. I mean, it's what you're saying. It's what you're saying. But one of my questions related to this is I had been at a conference a number of years ago where the issue of what looks like ADD with bipolar people had been raised. So I got very sensitive to it. And routinely now, I've seen it, and I don't know if that's related to some what looks like impulsivity and so on. And I routinely now, if it looks like that with people I work with, I send them off for an evaluation for that, and they are often started on some kind of Adderall or something like that. Once they're, and it's made the most astonishing difference in outcomes, because they tell me they can focus, and it allows us, not only does it shift some of the schema, apparent schemas, but it allows us then to work. and gives them, so I'm just passing that along to anybody else who works with bipolar people.
There's a lot of comorbidity. ADD is often diagnosed during childhood for these people or adulthood. Tons of comorbidity, and that's one of the things that we have to tease apart